of urination is not completed.
Oh, I'm so sorry to hear that. That must be very troublesome for you. Can you tell me when did the problem first started?
I have seen it from last 6 months.
Okay, okay. I'm so sorry. Okay, can you tell me, do you have any history of previous hospital admission for such kind of thing?
No, no history.
Okay. Uh, so do you have any problem to starting your peeing?
Sometimes I feeling hesitancy during maturation, during peeing, and sometimes I feel some pain also.
Okay. You are telling me you are having pain. Can you tell me the exact site of your pain?
I feeling pain during peeing in the line of water.
Okay, okay. I'm so sorry to hear that. You must be in very much pain right now. Can you continue this?
Sorry,
Can you continue this?
no, no. Sometimes during
Oh,
peeing only.
okay. Can you tell me, do you wake up at night to pass urine?
Yeah, yeah.
Okay,
I have to wake up for 2 times, occasionally 3 times at night.
okay. I'm so sorry to hear that. Do you feel like you are voiding completely, or do you feel like after voiding there's some urine left?
I think my urine is left in the bladder, not
Okay,
completely voiding.
okay, okay. So, how's been your weight lately?
It needs so many times.
Okay, have you lost any weight recently?
Yes, I have lost. My friends told me I have lost some weights recently.
Okay. How's your appetite been lately?
What is appetite?
Okay. Do you feel like eating?
Yeah, in nowadays I have decreased appetite.
Okay, okay. Do you have any bone pain?
Yes, yes. I have sometimes I feel back pain.
Okay, okay. So, can you tell me, do you have any, um, uh, do you feel any burning sensation during your peeing?
Yeah, yeah. I feel burning sensation sometimes.
Okay. Have you had any fever recently?
Yeah, sometimes in 2 weeks ago I have suffered from fever.
Okay. Do you feel any numbness in your legs?
No, no,
Okay. Did you pass any stone while peeing?
no, doctor.
Okay. Um, do you have any medical condition?
Yeah, I am suffering from diabetes mellitus and hypertension
Okay. For how
for
many
last
years?
for last 10 years.
Okay. Do you take any specific medication for all this?
Yes, I have taken some anti-diabetic and anti-hypertensive medications.
Okay. And can you tell me the name of those?
Sorry, I couldn't mention the name at this
Okay.
moment.
Okay, no problem. Uh, are you taking any, are you allergic to any anything?
I have allergies some foods like shrimp
Okay,
and
okay,
beef.
okay. Okay, now I'm going to ask you some personal question. Is that okay
Okay,
with you?
okay, okay.
Okay, what do you do for a living?
I am a businessman.
Oh, that's very great.
Thanks.
Whom do you live with at home?
My wife and my child.
Okay. Do you smoke or drink?
Your time is up.
No.
Okay. Do you have any issues with your mobility?
Fatima, your time
No,
is.
no, doctor.
Are you listening,
Time
Doctor?
is up?
Yes, your time is up. So,
Oh,
you like to present the case or uh, tell me the positive finding?
okay. Mr. Rios, 36-year-old, has come to me with the complaint of inability to pee with his increased frequency, urgency, poor stream, and incomplete voiding, and is training to urinate for more than 6 months. He is a diabetic and hypertensive, taking some anti-diabetic and antihypertensive medication, which name of which he couldn't mention. He also complained of weight loss and anorexia and some back pain for a few days. He is allergic to shrimp. He's a businessman and lives with his wife and child. From his history, my most probable diagnosis is benign prostatic hyperplasia, but I also have to consider carcinoma prostate, urinary tract infection, or any stone or neurogenic bladder.
Okay. So, how would you like to investigate the patient?
I would like to, at first, I would like to investigate by doing routine blood test containing a full blood count, UTI electrolyte, C-reactive protein, liver function test, group and 7 clotting screen. Then we'll go for urine analysis along with urine routine microscopic examination and culture sensitivity. Then uroflowmetry and uroflowmetry along with cystoscopy and an abdominal ultrasound scan with post-voidal residual volume and transrectal ultrasound with biopsy.
Okay. So, how would you treat the patient?
Okay, I will involve a multidisciplinary team to treat this patient, and I have to give, as a medical management, I have to give the patient either tamsulosin or finasteride. And if that doesn't work, we have to go for surgical treatment, which can be transurethral resection of prostate, or there can be open or laparoscopic prostatectomy.
Okay. Does people do the laparoscopic prostatectomy?
Sorry?
Is there any laparoscopic prostatectomy option?
Sorry, I did not get your question.
Is there any procedure or laparoscopic prostatectomy? Is it really done in daily practice?
Not really, but there's some option.
Okay, let it go. So, how was your history taking?
It wasn't good because at first I thought I would ask the question chronologically, but somewhere I got lost because uh, the patient actually said everything in the beginning and I had nothing left to ask. So I got very messed up. And then I did not ask family history, if I'm not wrong. I could not finish in time. I could not ask for his concern and any kind of systemic questions. Also, I think there is a little
Yes,
less empathy.
are you there? Do you have any comment regarding Dr. Fatima?
Hello.
Do you have any comment regarding Dr. Fatima? Yeah.
I have a comment when you told her present your positive findings. She told everything. I think this is not correct. These should be only positive findings, like Mr. Rias, 36-year-old, 77 years old, sufferings from features of LUTS and some back pain and anorexia, weight loss, and this only terminology.
Okay, okay, let's come to the point. Okay, Dr. Fatima, for the very first time, she did really very good. I can believe that she the first time. It's true she's with us for the first time, but she is a very expert, and she did really well. History taking portion, and she does practice. I don't know why does she practice, but she does practice. So the main problem with the Dr. Fatima is the timing. Timing is your main problem. So you are not totally aware of your timing, and that will really kill you in your exam. Because I always mention, if you can't go one or two differences, that's totally okay. But if you can't finish your history within the time, that is a real massacre, and that you lose a big amount of mark. So your most important deficiency is the timing. So you are totally aware, not aware of the timing. Because for say, I just looking at the clock, that in the clock, that you took almost one more than 1 minute just to seek the question, like uh, her previous hospital admission, or previous surgery, and drug history, and any allergies. Only for these two question you took almost 1 minute. And I was just saying on that portion that you are totally not aware of the time, because you took so many time, and you couldn't touch so many important portion that uh, does have some mark, and you will lose the mark from this portion, right? Did you get it, Dr. Fatima?
Yes, yes.
Your beginning was totally very good. Your introduction was good. You explained the patient. You took the consent. That's good. You took the permission to write it down, and your open question was good, and your empathy was good. But you didn't fluctuate your voice with the patient, like you were showing the empathy in the same manner. Just you were talking for the whole time, right? You'll have to uh, for the you have to show the empathy with the low voice, with a very cordially with the patient, right? So this is your weak point, I think. So you'll have to show the empathy properly. So
Yeah. I think I was nervous. That's why my voice got higher. I'm sorry.
so come to the you didn't take the family history, right? Family history.
Yes, yes. I
You,
forgot that.
you didn't get the time to mention almost one third of the whole history, most important portion, and that carries really a big amount of marks: systemic reviews, family history, personal history, and some other things you couldn't touch. The most important thing,
Yes.
presentation. I always said, like Dr.
Dr. Rifat, I have a question.
Sure, sure.
Dr. Fatima said multidisciplinary team approach. It is a benign case.
Come,
So for this case, it is correct or not?
we'll come to this point, just gradually, chronologically come to this point. In the presentation, I told you not to say so many things in the presentation, because you have maximum 1 mark in the presentation, but just you are allowed to say only the positive finding. So you could say like this: 77 years old Dr. Mr. Riaz came to me with the complaints of LUTS in the form of frequency, urgency, poor flow, and straining for the last 6 months. Patient has urinary retention, and one thing Dr. Riaz forgot to tell you, that patient is having alpha blocker for the nasal congestion. And
Yes.
in my real exam, patient was saying he was taking xylometazole this way, the alpha blocker. So the examiner will ask you what's the role of the alpha blocker and how the tamsulosin works. So what would happen tamsulosin when you will give the tamsulosin, and as the patient is having alpha blocker. So in my real
Mhm.
examination, doctor consultant asked me this problem that arises in this condition, and what is the how finasteride works. This thing my examiner asked me. So we'll have to answer this portion. So now come to the investigation. So
Dr. Rifat, can you please tell what will happen that alpha blocker and tamsulosin?
is the alpha agonist and gynometazolone is the alpha blocker. So now tell me the answer. Right, one is agonist and another one is antagonist. So the appropriate as there is a role of muscle relaxant, because why we use the tamsulosin. Tamsulosin is the muscle relaxant and the
And bladder relaxant. Yeah.
Sphincter alpha 1 blocker, tamsulosin.
yes, they really block all the smooth muscles so that the outflow can be relieved, so that the symptoms improve very properly. As the patient is having nasal decongestion like alpha agonist, so alpha blocker won't work properly, right? That's why patient will have to stop the xylomethazolone or oxymethazolone, whatever. Now come to the your presentation was not that much good. You said so many things like you was saying wife, he lives with wife and the children. So what's the role of living wife and the children in this condition? So could you tell me, Dr. Fatima, what's the role of living wife and children?
This is actually, I think, asked at as part of
No,
social care, because if people are dependent on him, if he is going to be in the hospital for the treatment, so obviously the patient will be anxious about his family at the home, no? I think from that background, this question is asked.
you asked this question in your um, question, but
Sorry, hello? I
you
don't understand.
you asked this question, this type of question, but you are not supposed to tell. Would you please?
Some noise
Sir,
background is
I
there, Dr. Rifat.
can't hear you. I'm sorry.
Okay, can you get it right now?
Yes, yes.
You took this history as a part of the history in the whole way, but in the telling the positive finding or the presenting the case is it has no role at all. So don't say unnecessary thing in the presentation. I always would like to say the positive finding just in a single sentence or two sentences. That's okay, because you don't
Okay.
have that much mark. Just concise your presentation within one or two sentences. That's totally okay. And I have faced this thing, and I said only the positive finding after having one or two sentence. Examiner appreciated me. So as a thing, don't go for the few more things during the presentation of the case. Okay.
Okay.
Now,
Thank you.
you are not supposed to say the differentials. You can say your provisional. The examiner will ask you the provisional, and you are not say the differentials until the examiner asks you. So don't say so many things, because
Okay.
you have marks in every step. If the examiner asks you, then say the differentials. If you can say the differentials properly, and if you answer those things willingly, and if you say those things wrongly, lose your marks. So that's why don't say so many things willingly until the examiner asks you, right?
Okay.
Investigation. You said so many investigations. I think investigations should come in a chronological way at first, non-invasive, like you didn't mention the one of the most important clinical in examination. One is DRE. You didn't mention it. And
Um,
did you?
yes, yes. Please finish. Please finish. Then I'll say.
So then come to the blood investigation like serum PSA analysis. You said there, but imagine and before going for the ultrasonogram, you said the cystoscope. So that's a great mistake. I think as the cystoscope is the most important tool or investigation tool that should be said the very last, or if the examiner would like to know directly, then go for the cystoscope. But before going to the ultrasonogram, you mentioned the ultrasonogram very lately, but you should have mentioned the ultrasonogram at the very beginning of your investigation. Whenever you come to the imaging investigation, just at first mention the ultrasonogram with MCC, with previous, with the poster, right? So you'll have to,
Okay.
most important thing, ultrasonogram. Then if you suspect the prosthetic malignancy, then go for the transrectal ultrasound guided prostate biopsy. and that is important. What is the indication? Basically, transrectal ultrasonogram posted biopsy is the inlets posted with raised one. Then you can mention if the patient is having ultrasound shows a large posted and the patient PSA is more and DL finding is suspicious, then go for the transrectal ultrasound biopsy. Then come to the treatment. In as you are having your first provisional diagnosis is enlargement of prostate or something like that. So don't go for the multidisciplinary team approach. You mentioned this multidisciplinary team approach and totally wrong, I think. So it's a benign case. I think that's why you can go for the according to the diagnosis. If the patient is having enlargement of prostate, you can go for the transurethral dissection of the prostate. If that is indication, right?
Okay.
So that's all
Um,
about for you. Is there anyone who wants to add anything regarding Dr. Fatima?
Dr. Rifat, I want to say anything. Um, like during investigation, we may tell urinary MCS,
Mhm.
ultrasonogram whole KOV with MCC and PVR and prostate, and serum PSA. These three things.
Yes, yes. I can
Am
see.
I?
Just if you don't go for the brother
And
and other not needed, just go for the urine RECS, say even serum creatinine. If there is any upper tract
creatinine, yes, creatinine.
change, then in the blood, go for the another investigation that is
Initially, I think this I should tell this thing.
yes, yes.
Then go for biopsy if needed after seeing the post PSA report and DRE examination.
You will have to mention the DRE very beginning of your clinical
History during history taking.
after taking the history before starting the clinical examination. You'll have to mention the DRE. Then
Right.
in the
Yes. Actually, I didn't mention that because you only said tell me the investigation. You didn't said the management.
yes,
If
yes,
you said management, then I would like mention DRE.
okay. I just only mentioned about the investigation. So DRE is not part of investigation. No,
Yes.
No, I think when a person says investigation, includes your examination also.
Actually, that is under management, not investigation, if I'm not wrong.
This is the part of clinical examination. I should tell I do some clinical examination of the patient and like DRE, digital rectal examination.
Yeah, you can't just jump to investigation. So, I mean, you can't say just like that. You can DRE is part of investigation.
Investigation. How?
no,
This is
I'm
a part
getting
of clinical
confused.
examination. Clinical examination,
Fatima,
No, it's a clinical examination. It's not investigation.
not investigation, right?
exactly. Examination is not the part of investigation. I didn't mention about the in my real exam. I didn't mention about the DRE when the
I
exam.
think every case, Rifat, I think every case in intra-abdominal we should tell about DRE. In Bangladesh, if we not say digital rectal examination, we will must fail, 100% fail
Not
in examination.
Even in MRCS, they mentioned in most of the notes that you have to mention examination with DRE.
Right.
so just whenever the examiner asks you, my examiner wanted to know about the DRE just after completion of the investigation. So my examiner asked me, is there anything especially do during the your examination? I just say, sir, I would like to go for the digital rectal examination. So what are you suspecting to have in your examination? I just answered. So these are the things. So that ends our second station. So
Thank you.
okay, you did a great job, Dr.